Alright, so we're just going to start with some basic cardiac anatomy. We have the right atrium, right ventricle, left atrium, left ventricle. Taking a look at this diagram over here, we see the deoxygenated blood returns from the body through the inferior and superior vena cava, empties into the right atrium, then moves into the right ventricle, and then is pushed out through the pulmonary arteries to go to the lungs to pick up oxygen. Once it picks up oxygen, returns back to the heart through the pulmonary veins, emptying into the left atrium, as we can see right here. Left atrium moves into the left ventricle. This is oxygenated blood up through the aorta and then back to the rest of the body so it can supply all the organs. The way it moves through the chambers of the heart is through what we call valves. So we have valves that separate the atrium from the ventricles. We call those atrioventricular valves, and we have valves that in between the arteries as well. Putting a little bit of focus on our atrioventricular valves right now. So we have the opening, which is called the annulus, with the cusps or the leaflets inside the valves. Then you can see the chordae tendineae and the papillary muscles. So these papillary muscles are attached to the base of the ventricle right here, and they support the valve. They're not contractile muscles. It also do not contract open the muscle. The only way the valves work in the heart is through pressure differences or pressure gradients. So when one chamber fills with blood, there's increased pressure in that chamber. The other chamber has lower pressure. The pressure gradient allows the blood to move from the high pressure to the low pressure, opening the valves. The papillary muscles are their sole purpose is to just support the leaflets and just anchor them in place. Alright, so now we're going to talk about some associated diseases. So what can go wrong? So the first thing we're going to talk about is regurgitation. So regurgitation is essentially the backflow of blood. As we talked about, blood enters one chamber, increases in pressure. When there's enough of a pressure gradient, the valves open, again, due to completely passively, not due to the contraction of the papillary muscles. Blood moves into the next chamber, again, and we have another pressure difference between the, for right now we're talking about the left, or the right atrium and ventricles. So that when the pulmonary artery has lower pressure, the valves open here, and the blood moves into that chamber. In regurgitation, which again is like a leaky valve or the backflow of blood, we see some cases where the blood moves back into the atria instead of all the blood moving into the pulmonary arteries. There's two different cases here. One, we can look at a genetic version of it, which we come down here. We see most people have a tricuspid system, which has got the three different valves for that valve, or three different leaflets in that valve. Some people have 4 leaflets, and it's completely genetic. And the 4th leaflet adds a little bit of space, so just because of that anatomical difference, a little bit of blood actually just ends up scooting back, and the leaflets don't close perfectly flush with each other. Or you can look at cases of prolapse, where one of the leaflets is weaker, so instead of being anchored down, it kind of flaps backwards and allows a little bit of blood flow to move upwards. Alright, so finally we're going to talk about some treatments that we could do. So if we look right at this first image, we have a papillary muscle with the chordae tendineae attached to it, very similar to this. If you take an excise of this image and put it right here. So again, in cases of prolapse, where we have this weakened flap, what happens is one of the papillary muscles, they get weaker and they get stretched out, and this stretching allows the valve to flap backwards into the atria. So the surgery that they do is they apply 2 sutures and they pull the papillary muscle close together. They kind of just pull it taut. And we have this looking papillary muscle right now with the sutures already in place. Looks very similar to the original. And that allows the valve to stay down and not flop backwards into the atria, allowing that backflow of blood. Another thing, if you have, again, in a genetic case where your valves or your leaflets in the valve don't overlap perfectly, you have this opening, they do what's called a plication of one of the leaflets. So in this case, we did an application of a posterior leaflet and remove that leaflet entirely. So now you just have the 2 leaflets left over, and they provide a much better seal in that valve than having the 3rd leaflet, which allows a lot of regurgitation and backflow of blood. Finally, in cases of infection, you have a normal looking valve with the opening between the leaflets very, very small, but in case of infection, the annulus gets bigger and opens, so the actual hole gets bigger, and the leaflets, because of they don't get bigger, they can't overlap and they can't provide that perfect seal against each other. So you do what's called an annuloplastic ring. And this ring sits directly over top of the valve, and they kind of pulls the annulus of the valve all together and keeps it nice and close together, allowing this opening to be much less. So again, this is not a perfect fix, but it does allow for much less blood to be backflowing to the previous chamber. Alright, so now that we've talked about regurgitation, we're going to talk about stenosis, which is kind of the exact opposite. So the regurgitation is this weakening or loosening of the flap, allowing for the backflow of blood, while stenosis is this stiffening or thickening of the valves, which prevent the forward movement of blood. Alright, so we can look first at the papillary muscles as well as the chordinae tendineae. In a normal case, we have these nice small papillary muscles and delicate or loose chordinae tendineae, and in case of stenosis, you have these thickened, lots of fibrosis and calcification around both the papillary muscle and the chordinae tendineae. And again, you look at the opening of a normal valve during the open state, and you look at it during cases of stenosis. We have this again, calcification, fibrosis, preventing of that forward movement of blood. So the opening is physically smaller and it's more stiff. We're just going to talk about two cases of critical stenosis. So the first one's going to be fetal aortic stenosis and adult aortic stenosis. Alright, so we're going to talk about fetal aortic stenosis right here. So in order for the left ventricle to develop properly, it needs constant flow of blood through it. This is in the fetus, of course. So in cases of fetal aortic stenosis, the aorta right here that the left ventricle feeds into has a stenosis, so there's not enough movement of blood through it, so it ends up closing off. This, in return, doesn't allow the left ventricle to develop because now there's not enough blood flowing through this. This causes the mitral valve to close off. So you have the mitral valve that kind of closes off, not enough blood going there, the left ventricle doesn't develop fully. All the blood in the left atria, therefore, starts moving into the right atrium through a little hole called the foramen ovale. When people are fully grown or after birth, this hole usually closes off, but in cases of fetal aortic stenosis, this hole remains open, allowing for this mixing of blood. So normally we have this nice red oxygenated blood from the lungs, but in this case, this blood mixes with the deoxygenated blood coming back from the body. We have this purpley mixy blood from the right atrium moving into the right ventricle, and then has to go back to the lungs to pick up more oxygen, which is kind of weird because it's already half oxygenated. And then the same kind of mixy blood is fed to the rest of the body through the aorta. Through another opening right over here called the ductus arteriosus, which again, in normal people, closes after birth. And so you have this mixing of blood around the whole body, not very practical, not very good. This baby will die as soon as it's born, if this isn't found within 24 hours after the birth. So again, if we just go over through what happens, we have this, we call this the hypoplastic left heart syndrome. So the left heart does not develop almost at all because it has very little blood flowing through it. The right side of the heart, the right atrium, the right ventricle is much more overdeveloped, and it does all the work for what both sides of the heart is supposed to be doing. It's all done by the right ventricle. So we have the ductus arteriosus open. Again, that's between the aorta and the pulmonary artery. We have the foramen ovale open, which is between the right atrium and the left atrium, allowing for this movement of blood from the left atrium to the right atrium. The mitral valve is closed, preventing this left ventricle from developing properly. And we have an underdeveloped aorta, again, because there's not enough pressure from the blood going through it, because we're just kind of getting this leaking a little bit of blood, as well as the left heart, or the left ventricle is not developed fully as well. Alright, so let's talk about some treatments for it. So most commonly uses the Norwood procedure, which is a series of 3 surgeries done to the child almost immediately after birth, and then a couple years later as well, and then another one a couple years later. And this child will also require a heart transplant eventually. So this is done in order to kind of start closing off all of these openings and allowing the left ventricle to develop slowly as the kid grows. Again, as I said before, this needs to be diagnosed between 24 hours of birth, or there's not enough pressure coming through the aorta to supply the rest of the baby, allowing for the baby to survive. Another procedure that's very recent, starting in about 2010, was the first time it was done, is correcting the stenosis right in urethral. So, and the balloon is expanded, allowing opening that stenosis, using the balloon to just literally increase pressure and open the stenosis, and allowing that aortic valve to be open, allow more blood to flow through the left ventricle and the left atrium, try and return blood flow and get proper development of those organs. So in adults, if you have the aortic stenosis, what we have to do is we have to replace that valve. So what they do is they use what's called the TCAV, or the transcatheter aortic valve replacement. And so a valve is carefully mounted onto a balloon delivery device, and the balloon is inserted up the femoral artery, travels up the aorta, and into the heart. It's guided through echocardiography and fluoroscopy, and the balloon, as it reaches the right spot of the heart, this balloon right here, it's inflated. So the balloon inflates, and attached to the balloon is a new valve. So it just kind of pushes the old valve out of place. You see the old valve kind of pushing the corner out of the place, and the new valve is inserted like that. Then the balloon is retracted and taken out the same way it came in. So the valve gets stuck in the opening right where the old valve is, just replaces it just like that. So this is for aortic valves, but how could they do this if it's a mitral valve? So the mitral valve, again, is between the left atrium and the left ventricle, right? So to get into this valve over here, what they have to do is they have to feed the catheter up through the inferior vena cava, so it's the femoral vein, up through the inferior vena cava, through the right atrium, through the left atrium, and then put it in place right over here. So it's a very intricate procedure that comes in like this to replace this valve. I'm going to talk about the melody valves. This is another very, very new procedure. So if you think about this case with a stenosis in a child, and you need to put in a new valve, the child's going to keep growing. You have to keep putting in new valves in this procedure every so often, because the child's going to keep growing. So the melody valve is a valve that actually grows with the child. So you put it in the same way, it goes in, and it expands with the child. So as the child's aorta expands, the valve expands to fit the space. So it kind of grows with the child and develops as the child develops.